We won't discuss which patients will require enteral or parenteral nutrition. So indications will be in different chapters. Okay, so a few would be, let's say, patient is a stroke patient. So basically, any patient who has an impaired ability to chew and swallow will have to receive nutrition via the enteral route, meaning through the nasogastric or gastrostomy or jejunostomy. Again, patients who have an impaired ability to chew and swallow, so that would be critical patients, obviously. Patients who are intubated, can they chew and swallow? No. Okay. So various reasons. So we will just discuss what are our nursing responsibilities when we are giving enteral nutrition. Then we will follow that with parenteral nutrition, which is on the next page. Now, the decision to give nutrition artificially via the enteral route means that the patient's GI tract is functional, is it not? Yes. Okay. So that's the number one requirement here. So whether we did or before we decide to do artificial nutrition via the enteral route, we must have evidence that the patient's GI tract is working, that they're able to digest and absorb the nutrients, correct? Okay. Then so therefore, obviously, if the patient doesn't have a working GI tract, is this an option? No, then the only option would be the parenteral route, IV nutrition. Okay, so let's discuss enteral nutrition first. So we bypass the normal chewing and swallowing process. So we go directly to the stomach or the small intestines. So there's two ways to achieve this. Either you have a nasogastric feeding tube or a endoscopically placed feeding tubes like a PEG tube, for instance, a gastrostomy tube, or a jejunostomy tube. So here are some indications. So who gets it? Major malnourished patients like alcoholism, for instance, those on cancer treatment, meaning they already very cachexic. You know what cachexia means? You've seen people who are skin and bones, right? Okay, so that's what we call cachexia. Comatose patients, obviously they can't swallow, so we won't let them chew or swallow anything. Convalescent care, debilitation, patients who have failure to thrive, diagnosis, again, bedridden patients, no energy to do anything. So we please also consider the ethical factors here, because unless the patient has a advance directive or a living will indicating that they do not want artificial nutrition, then the assumption is that we give artificial nutrition. You've heard of the case of Terry Schiavo? That was in the early 2000, I think 1999 or early 2000. Pope John Paul II was still alive at that time, so he weighed in on that case. The Catholic Church has since changed their stand on artificial nutrition. They made it from basic care, meaning they did not consider artificial nutrition as extraordinary measures. They considered it basic care. Now they changed it to comfort care. Okay, so the church again has, because of the many issues, many debates, so they've changed their stance now from basic care because it affected, right? Meaning there are Catholics that, of course, would not be in agreement with prolonging life because of that reason, because the church said this is basic care. So therefore, if it's basic care, you cannot deprive someone of basic care, correct? Meaning it forced a lot of Catholics with end of life diagnosis, terminally ill Catholics, to receive artificial nutrition because the church said it was basic care. So if you refuse basic care, then that's tantamount to suicide, right? But now they changed it to comfort care. So now more Catholics are now, at peace with putting that in their living will, that I do not want artificial nutrition. Because this, once we put in a feeding tube in a patient, their life is extended indefinitely. So even if this patient is in a permanent vegetative state, meaning brain dead, as long as you feed that body, they live indefinitely. They can live to 100. A child, let's say, is brain dead, they can grow into a teenager and into an adult in that state. Do you understand what I'm saying? So there's a lot of implications here, okay, with artificial nutrition. So consider those, okay? Maybe if you have probably not concerned about that right now, but eventually we will have to make those decisions, right? Yes. I mean, again, it's all about quality of life. I mean, what's the reason you want to keep that patient alive? Wherein there's no chance of recovery. I mean, they're brain dead or in a vegetative state. So, and the child obviously can't make decisions. So again, it's to each his own. Okay, so parents sometimes can't let go. So again, the individual reasons. Okay, so nobody can tell you what to do, but just consider these issues, okay, so these are things we discuss when we ever are talking about enteral nutrition, because the implication, again, the result is the patient receiving enteral nutrition will live indefinitely, right, unless they develop complications, which we'll talk about today. So these are the various patients that will require either temporary or long-term enteral nutrition. So here are the ways we can achieve enteral nutrition. So you can go the nasogastric or nasoduodenal route. Okay, so meaning you put in a small bore feeding tube, French 14 or 12, put it through the nose into the stomach, take x-rays to confirm placement, and there you go. You can use the feeding tube. Some for long-term, obviously, if it's nasogastric, is it long-term? I mean, can you do it years having no? So that'll be for short-term, right? So maybe a few weeks or a couple months we can do nasogastric, but long-term here for the rule is for patients with requirements needing a feeding tube longer than 4 weeks, then we're better off with a PEG tube, okay, a gastrostomy tube, jejunostomy tube. Okay, so we have a table. We'll look at that table shortly. I won't do the solutions. Again, are we the ones prescribing the feeding, the formula? No, so we'll skip all that. Let's go to our responsibilities now, which are the administration methods. So when we give the feeding, there's two methods of administration, either a closed system or an open system. Regardless if it's nasogastric or PEG tubes, we can do an open system or a closed system. When we say open, so this is one method of open. So we give the patient bolus feedings as opposed to continuous feedings. So this is open because this is the patient's feeding tube. We attach a syringe to it. Then after we confirm placement, we'll discuss how to confirm placement shortly. And then you give them the feeding, either straight from a can or from a different container. The doctor and the nutritionist prescribes how many cans. They usually do it by calories, which equivalents to a number of cans spread throughout the day. They usually follow usual meals, breakfast, lunch, dinner, just like regular people when you would otherwise eat a meal, but in this case, they're just using it in they're eating formula instead of regular food. So this is called bolus feedings, or also called intermittent feedings. The patient can do it themselves, or this can be administered by any healthcare giver, including healthcare providers like nurses or LPNs. Continuous feeding is only achieved through a feeding pump, because we can't pay somebody to put in small drops of liquid continuously, right? So we need a feeding pump. Most common brand is the Kangaroo. You also use Kangaroo in your facility? Okay. I think that's it, right? I haven't seen really another. Well, there's Kendall. Wait a minute. Kendall makes Kangaroo, right? Yeah, so it's the same feeding pump. So here's a typical looking feeding pump, Kangaroo. Easy to set up. So this is your feeding. Nowadays, we have two. There's the commercial feeding or commercial formula bag or bottle. And then right next to it, just like you saw the blood tubing earlier. So we had two, right? Two spikes. So nowadays we'll also have two. The other one will contain water, no regular water. But most facilities use sterile distilled water. We don't use saline, because do you drink saline? No. Okay, so for feeding, we use sterile distilled water. Or tap water is actually fine. I mean, do you drink sterile water? No, no need. As long as you do it properly. But again, most facilities use sterile distilled water. So the pump does everything. All you need to do is prime the formula and the water. The pump can even prime it for you. So you just press a button, it will prime the tubing. And then you put the settings there, the rate, just like an IV pump. Put in the rate, the volume, and then you also, in the case of, because you can set the pump to flush the patient with water automatically, so you don't have to manually give them water. So the pump will do it. You choose the frequency, how often do you want the pump to give them water, and how much water each time. So usually Q6, you put it every 6 hours, give them 100 ml of water, or 150, whatever the doctor or the nutritionist order is, okay? So here are our responsibilities now. So chart 39-5. First is always assessment. So before you even start the feeding, first thing you do is tube placement. There are many ways to achieve or perform tube placement. The initial is always a chest x-ray. No, sorry, not chest x-ray, abdominal x-ray, sorry. So the NG tube or the PEG tube was just put in today. So the doctor will order verification, initial verification, x-ray, always x-ray. The tube has a radiopaque lining on it, so it will show up on x-ray, so you can easily see where is the tip. Is it where it needs to be? Is it in the stomach? Is it in the jejunum? Is it in the duodenum? Wherever the doctor wants it to be. And then once we get that confirmation, then we can use the tube. Is it practical to do chest x-ray every time we use it? No, it's only done one time. And also as needed. So let's say you doubt the placement of the tube. Okay, so you as a nurse, because you were the ones giving the feeding, you have suspicions. I doubt it's in the right place. Okay, so patients showing you indications of choking, for instance. Okay, that or the tube marking is not in the right place, so you suspect it. So raise your concerns to the provider, and they'll be happy to order a chest x-ray for you. Okay. Placement, so that's placement. Position. All patients must be at 30 degrees head of the bed elevation or higher. So we go 30 to 45. The problem with 45 is the patient now has a high risk for developing shear injury, pressure injury with 45 degrees. So that's why we prefer 30. Okay. Because if you're on a feeding, if you have a feeding tube, are you mobile? Chances are you're not, right? So between 30 and 45, what's the better choice? 30 degrees. So these are our intubated patients in the ICU or in long-term care, for instance. Obviously, immobilized, bedbound patients, high risk for pressure injuries. Patient's ability to tolerate the formula. Observe for fullness, distension. We also need to check for the residual volume, specifically gastric residual volume. That means we'll have to connect the feeding tube to a syringe, aspirate the abdominal contents, and then measure how much is in there. All right, are we clear? Okay. Because they're regarding stool pattern, because this is liquid nutrition, they're eating nothing but formula. Do we expect diarrhea to be the normal bowel elimination pattern? No. Okay, diarrhea is never normal. Are we clear? Babies eat nothing but formula. Does that mean babies have diarrhea? No. Do you have, how many children do you have, John? One? So your baby had diarrhea the first year of life every day? No, not diarrhea, right? Okay, so they have soft stool. That's supposed to be the output. Or sometimes, depending on the formula, they can also be constipated. Formula has no fiber, then they can get constipated too. But diarrhea is never normal, okay? So when the patient has diarrhea, when do we consider it diarrhea? 3 days or 3 episodes? 3 episodes. So 3 episodes or more of liquid watery stools, that's diarrhea. What's your responsibility? Report it to your physician, because most common reasons for diarrhea is they do not tolerate the formula. Their stomach, their intestine does not agree with this formula. So the doctor can try changing the formula. If it continues, we've tried several types of formulas. They usually don't wait, so they just say, okay, they order, okay, change this to change the feeding to this formula, and then send a stool sample. That way they save time. So we send a stool sample just in case it's something infectious, okay, that's causing the diarrhea. And then to evaluate, is our nutrition working? What's the best evidence of good nutrition? That the patient is getting enough nutrition? Weight. Is it daily or weekly? Does the weight change daily? We're not trying to evaluate fluids here. We're trying to evaluate nutrition. So does the nutritional status change day by day? You can't see the changes, so it will be weekly weights. Okay, so for nutrition, weekly weights. Are they gaining or maintaining weights? Okay, obviously if they're losing, then we're not achieving our nutritional goal. So more accurate indicators though are the following. So BUN, protein, because if the patient is malnourished, will they have normal protein and red blood cell values? No. Malnutrition, number one manifestation is anemia. Okay. Signs of dehydration, remember, that's why we have, although we can't say that because they're getting formula, that's already water. No, they still need free water. So that's why I explained earlier, there will be two bags hanging. Okay, one for formula, one for water. They still need water. Now, the basic solution is, of course, there's glucose in the formula. So always check for hyperglycemia or hypoglycemia. Then sudden weight gain. So these are all complications. So sudden weight gain, that means this is fluid overload, right? Or indicating heart failure or decreased urinary output. Are they receiving enough fluids? No. Okay. Then other signs of fluid overload, so edema around the eyes or in the legs. Signs of infection. Now, the infection here is because of the equipment. The rule is because let me show you the picture again. So if it's a commercial bag, then that means this is a closed system, which means the formula bottle is spiked with a tubing, just like an IV bag. And it can get contaminated, meaning you didn't wash your hands or you use bare hands when you spike the container. The problem is usually with the water bag, because the water bag is not commercially prepared. It's literally just a bag and then you fill it with distilled water. No matter how sterile the water is, if it's sitting for 4 hours or longer, is it going to grow bacteria? Yes, because it's an open system. So the rule is we only put 4 hours worth of water there. So if the flush is 100 every 6 hours, how much water should you put in the bag? 100 every 6 hours. 100. Okay, 100. Because you don't want bacteria to grow. But what most nurses do is they'll fill the whole thing up. Okay, so definitely more than 4 hours. So where mostly is the contamination occurring? In the water. No matter how sterile that water is, it will grow. It will grow organisms, okay, if you let it sit there for too long. Just like any other water, you leave water uncovered on the table, of course it's going to grow bacteria. The most serious complication while we're at infection is peritonitis, so related to the feeding tube, right? So the feeding tube got infected, there's contamination there, and then it infected the stomach and the peritoneum. So that's serious. So here's the weekly weights. Again, if you have any concerns, consult the dietitian. All right, here are our responsibilities. Let's start with the residual volumes. Now, follow your textbook. Every facility will have a different rule on how much residual volume before you withhold the feeding. So your book says in excess of 250 to 500. So therefore, what is a acceptable gastric residual volume here? Less than 250. Okay, again, follow your textbook. The individual facilities will have a different rule or policy. Most of them will say 150. Okay, so this one, because how much is 250 anyway? That's one glass, right? That's one cup, 240. So it's not really that much. All right. So so what are the ways again we check placement of the tube? Abdominal X-ray, initial, and then what about succeeding? How do we know it's still in there? Okay, we don't see that in textbooks anymore, right? So we call that air insufflation, meaning what she's describing is we attach a syringe filled with air, correct? To the end of the feeding tube, and then we put our stethoscope over the left upper quad, correct? And then you flush the air in quickly, and then if you hear the sound, that means it's in the stomach. Okay, so evidence shows though that regardless of where that tip is, even if the tip is in the esophagus, you will still hear the air when you flush it. So is it conclusive therefore? No. So that's why you don't see that in textbooks anymore. Is it done in practice? Absolutely. Okay, nursing, long-term care facilities, hospitals, they still use that. But is it still in the textbooks? No. So I doubt if they'll put that on the NCLEX because that's not really evidence-based anymore, but they can't do anything in actual practice though. Nursing NCLEX recognizes that it's done everywhere. Okay, nurses are still using that as a means to check placement. But again, is it evidence-based? No. The more reliable ways is to, one, check for residual, okay, and then check the pH of that residual. If it has a acidic pH, depending also if it's in the stomach or in the jejunum or the duodenum, different pH levels, as long as it's acidic, then that means, is it in the airway or is it in the GI tract? It's in the GI tract, right? So that's the most conclusive evidence next to x-rays, okay? Another way to check is they'll put a CO2 detector, a capnometer. You know what I'm talking about? It's a device that will detect the presence of CO2, carbon dioxide. So if the CO2 level is high or normal, where is this tube? It's in the lungs. Make sense? Okay. So therefore, if the CO2 is low, then that means most likely it's in the stomach. So those are the more reliable ways next to chest x-ray. So we check the pH, and then we also check for capnometry. Flushing of the tube is essential to make sure the tube remains patent. So when do we flush? Before and after feedings, intermittent feeding. Intermittent, the bolus, you put the can. Okay. So if it's continuous feeding, we do it usually every 4 or 6 hours. If it's continuous, okay, we still need to flush. Before and after medication administration. Now, medications given through a feeding tube must be liquid, although some medications, there is no liquid form, so we have to crush medications. We have to crush tablets. If that's the case, please place them separately. It's not really a good idea to bunch them all in one cup, dissolve them, and expect them to not clog the tube. That's the most common cause of, especially nasogastric tubes. Nasogastric tubes are small bore feeding tubes. Okay, PEG tubes, okay, they're huge. Okay, they're huge tubes like this thick, but nasogastric tubes are very small. They will get clogged if you give crush medications through there. Are we clear? So if you have to give crush medications through a nasogastric tube, make sure it's really diluted. What do you mean by diluted? Yes, so plenty of water in there, right? And it's also not a good idea to mix them, because once you mix them, you don't know how one powder reacts to another powder. Okay, because the contents are not the same. They can form clumps. Now, next thing you know, the tube is clogged. You can't give the feeding. You can't give medications. You call your resident. Of course, what will the resident say? Who clogged that tube? They don't use it. So who clogged it? You did. Sometimes it's not used, probably the nurse you followed, but since you did not verify during shift change, you didn't verify that the tube was, you just trusted the nurse, you didn't verify that the tube flushes during shift report, then it's your problem. The assumption is you clogged it. It happened in your shift, right?
So what happens on the night shift? Was there some verify? The nurse has to see that tube?
Say again.
I said, what happens if I come in the morning, right, and then I verify with the nurse, and it's clogged? The nurse has to stay and change it?
Not necessarily, but it will be written up. Reflects poorly on you. Okay. But the resident whoever's on duty is required to change it. Unless it's extremely busy, there's no time, impossible to do it during that shift. Okay, so it is every 4 hours if it's continuous feedings. Okay, you flush after checking for gastric residuals because the stomach contents are thick. So after you check, then you need to flush. Or if the feeding is discontinued, meaning or interrupted, meaning the feeding is stopped, nothing's running through the tube, make sure you flush the tube. So as I mentioned earlier, water is used. As to what type of water, distilled water, sterile, or tap water, follow agency policy, okay? But at home, it's usually tap water. I mean, that's what we drink, right? So here, use of sterile water is the best practice, especially if the patient is immunocompromised. Medications. So this paragraph would tell you do not mix different medications together. So you pause the feeding, flush the tube first, then make sure your medication is either liquid or dissolved properly if it's a crushed tablet. And then to minimize, because it can add up, right? If you give 30 each time, let's say the patient has 20 pills to take, how much water is that? If it's 30 in between, that's a lot of water, right? So water alone, that's already over 600 ml, right? So we can do 15. So medication, 15 of water, medication again, 15 of water. Okay, at least we'll cut down on the total amount. So use proper nursing judgment, okay? When you're giving the, especially with medication administration. Ideally, again, all medications should be in a liquid form, but some medications don't have a liquid form. I already mentioned that. Okay, closed systems are preferred, obviously, for decreasing the incidence of contamination and infections. So here are the problems with enteral feeding. So you can have constipation or diarrhea. Here, constipation, diarrhea. And here are your responsibilities for each one. So I mentioned earlier for diarrhea, then check for formula tolerance. And if not, check medications and then discuss them with your your provider. How do we prevent aspiration? Head of the bed must be 30 degrees. How else? Checking placement, right? Yeah, checking placement of the tubing. Make sure it's still in the right place. How else? Well, flushing before and after really just ensures patency, correct? Make sure the tube is not clogged. Yeah, that's about it. Positioning and placement. Yeah, placement and positioning. So if the tube, or you suspect tube displacement, until you prove otherwise, what's your number one responsibility? Stop the feeding. Okay, do not risk it. You suspect the tube is not in place. You're concerned about nutrition, yeah, but we're more concerned about pneumonia, aspiration. Okay, patient aspirates because the tube is not in the right place. That's the more pressing priority. Obstruction, again, who causes these obstructions? Nurses. Nobody uses it. Nobody else uses it. Only RNs and LPNs are using the tube. So they get clogged, it's on us. All right. Okay, so hydration, we mentioned there should be regular flushing. Okay, dumping syndrome. And then we'll proceed. This will be the end, and then we'll proceed with, we have peritonitis, I think. No, we'll end at dumping syndrome. So what is dumping syndrome? Any idea? Who are familiar with gastric bypass surgeries here or know someone who had one? Because they're the ones that frequently experience dumping syndrome, right?
Yeah.
Okay. So what's the cause of this?
I did. I did the surgery, but I didn't.
Okay, very good. Who else knows about dumping syndrome? Okay, so basically, so in gastric surgery patients, that means because the stomach is so small now, or sometimes they don't have a stomach to speak up, um, the food instead of because it's supposed to do what food is supposed to sit in the stomach, correct? That's the normal physiology. So food, whether solid or liquid, is supposed to sit in the stomach for how long? 1 to 2 hours. And then what's the food doing in the stomach? Right. So being turned into liquid, right? So your acids there, pepsin, gastrin, are being secreted, hydrochloric acid, turning the food into liquid. And then 2 hours later, it enters the duodenum already in a liquid form, ready for absorption. We don't have that process here because the liquid goes straight, correct? Because you're eating formula. So that means is the food going sitting as it should in the stomach? No, it goes straight to the duodenum, and that causes the dumping syndrome. So the manifestations are very unpleasant. Okay, so causes nausea, vomiting. Patient feels like there's indigestion. They have a sudden rise and fall of their blood sugar. Okay, so that causes them to have these sensations of high blood sugar and then low blood sugar. All right. So and then abdominal pain. The discomfort is the most pressing symptom. Okay, so the belly hurts, just not feeling well. Okay, and then imagine feeling that every day. Okay.
She did that, and every time they have to do a procedure after.
No, it's just a matter of complying with what the instructions are. So most likely that the patient was not complying with the instructions. So it's a matter of complying with the instructions, both with the consistency, amount, and how often they eat. Because it's not easy. I mean, basically, if you know this, right? I mean, if you undergo gastric surgery for the purpose of weight loss, you're basically starving yourself. Yeah, that's weight loss by starvation, correct? No wonder, I mean, why do you think they're given B12 injections? Because they're malnourished, right? Yeah. Exactly, because there's no stomach to absorb those vitamins. Anyway, that's my 2 cents. All right. So any questions on enteral feedings? Okay, one more, enteral parenteral now. So the IV nutrition is last.
No, we didn't. We should.
No, we can talk.
Next week we have lectures still, right?
After the exam.
And then the following week is a still lecture? Yeah.
After the, no, before the ATI retake. Because we have class first.
Yeah. We just after?
Yeah, so that's why the lecture comes first, and then whoever doesn't need to test, then you can go home.
So next Thursday. For 7th, no, next week is our 30th.
Yeah.
Okay. And then the 14th. It's ATI and we have a lecture. So we have a lecture the 7th and the 14th. And then the following week is our final. Yeah, we learned new topics for other 2 lectures. Oh,
Okay, page 1313. Almost there. So this is obviously the choice if the GI tract is not available. So many causes, the patient has some cancer, some malabsorption problem, or let's say intractable nausea, vomiting, etc. Whatever the reason is, we're giving the nutrition parenterally. So let's say a patient doesn't have a stomach, they don't have a GI tract. Okay, they lost it all to cancer. So now they'll have to live their lives getting parenteral nutrition. Two ways to achieve this. Either you do partial parenteral nutrition or complete parenteral nutrition or total also. So either partial parenteral nutrition or total parenteral nutrition. When we say partial, that means the patient is still eating by mouth, but it's not enough. So we give it through parenteral route. If that's the case, if it's partial, the formula has a different concentration. It can be given peripherally through a small vein. Are we clear? Again, if it's partial, that means patients either eating partially, little bits there, liquid nutrition, ensure, but not enough. They give it parenterally. So it can be given peripherally on a small peripheral vein. If it's total parenteral nutrition, since the concentration of the solution is thick, we're talking about 10% dextrose or higher, it can't be given through a peripheral vein. Too thick. The small peripheral vein cannot tolerate thick solutions like that. So it has to be given through a central line. So we talked about central lines, right? In lab during week 1, week 2.
Yeah.
Okay. So here are some indications, fever, blah, 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 whatever is the reason. So the patient now has, here are some of the indications also. So the patient receives it parenterally. You have the complete list, table 41-6. So all of these patients here are candidates for parenteral nutrition, either partially or total. One to 3 liters of the total parenteral nutrition. Who prescribes it? The doctor will indicate how much calories, that means how much dextrose is in there, how much albumin is in there, because it's, well, actually it's not albumin, it's amino acids. So it's the basic building blocks of carbs, protein, and fats. Okay, so the basic carbohydrate is dextrose, correct? And then the basic protein is amino acids. The basic fat is lipids, correct? So those are the 3 contents of the solution. Lipids will be in a separate bag because they're not going to be compatible with dextrose and amino acids. Amino acids are, if it's in storage or let's say in the pharmacy, they are separated, but right before you administer, you will mix them together. So the dextrose and the amino acids will be mixed, except the lipids. Lipids will look like milk, a bag of milk. It will be coming separately. Okay, but they go into eventually meet in the bloodstream. Okay, but separate tubings. Does that make sense? Okay. So it's given over a 24-hour period. In practice, it's actually 23. Okay, especially if the patient is outpatient. In the hospital, of course, we can afford to give it 24 hours because we're a 24-hour facility. In the home, if the patient's getting this at home, it's 23 hours. We give them 1 hour for hygiene and preparing the next formula because we need to change the tubing every 24 hours. Is that clear? So 23 hours at home, we give them a break, 60 minutes, that's it. But those 60 minutes isn't like leisure. I mean, what can you do with 60 minutes, right? It's basically preparing the next bag of formula, changing the tubing, and then getting dressed. Okay. In the hospital, again, it's 24 hours. Let's go to our responsibilities. Here's a warning. So just like any other bag, IV bag, if you suspect contamination or there's risk for contamination, the bag is leaking, cracks, whatever, there's something cloudy in the solution, don't use it. So let's say the patient has a peripheral line, so no problem with that. Anyone can insert the peripheral line. But if it's total parenteral nutrition, we need a central line. So the doctor has to insert the central line, or an RN can insert a PICC line, whichever is the decided venous access device. So here's the peripheral method. So the formula again is not as concentrated as the TPN. Here's the TPN, which is the central method. Look at the concentration of the solution, 2,000 milliosmoles per liter. That's a very thick solution. So we need central venous access devices for that. So I mentioned a few in week 2, right? So we have 4, correct? PICC lines, non-tunneled, tunneled, and ports, okay? So any one of those 4 central lines can be used. So I won't discuss that. We did the central lines already. Let's go now to our responsibilities. So all these paragraphs are talking about the venous access devices. Okay. Parenteral nutrition. When we discontinue it, which can be either intentional, meaning we plan the discontinuation, or let's say it's accidental. It should not be sudden. It should be gradually tapered off, similar to steroids. Now, what would be unintentional? Let's say the pharmacy ran out, or if this is in the home setting, they ran out of the TPN solution. Say major hurricane, the road is not accessible for weeks. Okay, and these are up to 3 liter bags. Can a drone drop something this heavy? Okay, so it's not easy, right? So logistics wise, so if it's the case, meaning we run out of it, the patient will always have a backup. The backup is 10% dextrose solution. So at least they won't die, because dextrose is carbs, correct? So they'll have enough calories to sustain them. They won't die. They won't have the proteins, unfortunately, but at least they won't die of starvation, okay? Because we have a backup 10% dextrose solution. So the patient will always have dextrose solutions. They should never run out of it. These are for emergency purposes only. Obviously, what is the more pressing consequence here when you're giving concentrated nutrition like this? Is it hypo or hyperglycemia? It's going to be hyperglycemia. Because you're using a central line, what's your number one concern? Infection, sepsis is the number one consequence. So since they're having high concentrations of glucose, which the body doesn't have to do anything because it's already in its basic form, meaning unlike food wherein we have to break it down, turn it into sugar, right? This one is sugar already going straight into the bloodstream. So is it a good idea to help the patient with insulin? Yes, some of these solutions will contain insulin in the bag already mixed. So that way we avoid the hyperglycemic episodes. So these are the consequences if, let's say, you discontinue it for, for whatever reason, unintentional, meaning unscheduled discontinuation is hypoglycemia. And these are, you still remember signs and symptoms of hypoglycemia? We did this in exam 2 or 1 when we did DKA, exam 1. Yeah, 1. All right. So tachycardia, confusion, diaphoresis, okay, pallor. That's about it. And we already discussed the central line dressing change early in the semester. If